Wow. So we're recording this conversation, so I'm going to just start by saying that we've just seen a screening of Peaceful by Emmannuelle Bercot, and we're here at Columbia University. And really so happy to have Gabriel Sara. I'm tempted to say Gabriel Sara, the French way. Dr. Gabriel Sara and Dr. Lydia Dugdale to talk with us about the film. So I'll just very briefly say a word of introduction, and then we'll get right into the discussion. And we will save time for questions from you towards the end of the discussion too. So please think about what you might want to ask. Sorry. So Dr. Sara grew up in Lebanon and began his medical training in Lebanon and then continued in France, where he got his doctorate, and worked for a time as an intern in Beirut. And I hope that we'll have some time to talk about that. And then came to the U.S. for his residency, including a year spent at Columbia in the late 80s. He's the senior attending physician in the Department of Medicine at Mount Sinai West and serves as the medical director of the chemotherapy infusion suite and the executive director of the Patient Services Initiative. He also teaches as assistant professor of medicine at the Icahn School of Medicine at Mount Sinai. And I believe you're you've just retired or you're very close to retirement.
I just retired.
Okay. And Dr. Lydia Dugdale is the Dorothy and Daniel Silverberg Associate Professor of Medicine at Columbia University College of Physicians and Surgeons and Director of the Center for Clinical Medical Ethics. She also serves as the Associate Director of Clinical Ethics at New York Presbyterian Hospital, Columbia University Irving Medical Center. She is also a practicing internist and came to Columbia in 2019 from Yale University, where she was the Associate Director of the Program for Biomedical Ethics. And her scholarship focuses on end-of-life issues, medical ethics, and the doctor-patient relationship. She's the editor of a book called Dying in the 21st Century and the author of a really beautiful book called The Lost Art of Dying, which I recommend to all of you. So thank you so much for being here. It's hard to even know where to begin after seeing such a remarkable film. This is my third time seeing it now, and I'm really so moved by it. And I'm really sorry to hear you're retired because I want you to be my doctor. I mean, actually, the first time I saw this movie, I didn't know what exact role you had played in it, and then found out subsequently, and I think it would be really interesting for the audience to hear from you how you went from being a doctor to playing a doctor very much like yourself in this film. How did this happen?
So first of all, thank you for inviting me. Thank you for coming. The story, I say this is a definite New York story, even West Side New York story. My wife and I love cinema, so we go to the movies a lot, and my wife subscribed to the Lincoln Center, Walter Reed Theater, and so she picks the movie we're going to see, and so when there is the French Cinema Week, we see almost all of them as much as we can, and she picks what we want to see, and then when we go, one day we see a movie called Standing Tall. Standing Tall in French, La Tête Haute. It's a story of a young delinquent kid who is in a rehab center and is struggling to just recover his freedom and dignity. And that's what he describes in the movie. In the movie also, Catherine Deneuve was the judge for the children who would evaluate this kid periodically, and his coach was Benoît Magimel. And the director was Emmannuelle Bercot. So we saw the movie and we loved it. I was very impressed by her depth of understanding the human tragedy and the way she described the struggle of this little young kid. And then we had the Q&A, and at the Q&A she was just amazing. Her answers were so profound. I was very touched. And before that movie, I have to say that I've shared my philosophy with people who know me in medicine, and I would say my wife would keep telling me, "You should write a book. You should write a book." I'm going to have you write a book. And then so we start thinking about it seriously. She told me I'm going to start writing some stuff about it. And then we were that day in the movie, and I just got a strong attraction to go and speak with Emmannuelle Bercot. I said maybe she will do a movie about some of our beliefs. So I rushed down to speak with her, and there were like 30 people around her trying to talk to her. I had to like grab her attention, so I was trying to raise my head so she can see me. I'm not very tall. And then we look at each other, and I tell her, ma'am, would you like to go in the trenches of cancer? I just said that without thinking. I didn't remember I said that. She told me I said that to her, and she put it in the movie, by the way. So this shocked her, and then she looked at me and said, I said, I work next door, and maybe I can show you things. I said, why not? I said, how can I get in touch with you? She said, that's my email. So we started corresponding. And the rest is history, basically, from emails. She came back 1 year later to New York. We spent a few days together. I made her visit the hospital. We met every evening. We discussed my days with her. She would ask me questions like an FBI agent about my day, and I would give her details. We happened to have a tango session that week, and also a morning conversation with the nurses. So I invited her to see those two things, which she loved. And a few months later, she told me that I'm going to do a movie. And a few months later, we are ready for the movie. We pick the actors, and we need a doctor. We need somebody for the doctor's role, and I think you'll be the best guy for the role. And I read this email. I had a little heart attack. My reaction when I had this is I sent the email to my wife, who was here. And I told her, look at what the mail sent me. And Nada never calls me on my phone. Never. She always texts me first. But this time she just called immediately. I was in the middle of round and picked up. Said, did you read the email? I said, yes. No, you did not read the email. I said, no, I read it. Said, no, go ahead, read it right now. Read it. So then I read that there was Catherine Deneuve, Benoît Magimel. I realized this was big. And at the end of the email, she said, I know it's a big challenge, but together we can make it. So that's the story. And then eventually I went to Paris, did the casting session. She tested with many other actors, and she picked me. So that's the story.
Well, I can see why she picked you. You're really a natural at this. And I wondered if you could tell us a little bit more about how much time she spent with you and how much your own practice is visible in what's shown in the movie. How much did you really have an influence on the dialogue, on the kind of atmosphere that's shown in the cancer hospital?
So after she decided to write the movie, she actually called me before she told me I was going to be in the movie. I knew nothing till the end. She said, "Listen, if you want to make the movie, I need to come and spend 6 weeks with my co-screenwriter, and we have to meet and talk, etc." So of course I was thrilled. She came. So almost every night after my day, I'll meet her with her co-screenwriter. We'll go for a coffee or dinner. And she will start telling me to describe my day. So I'll tell her about this patient, that patient, etc. Of course, without names. And she'll be like scribbling the details with her co-screenwriter. It was really impressive. But I love those moments because they were so interested to learn all these things I have to share with them. I had them meet my nurse practitioner, whose name is Shanny, by the way, like in the movie. Mm-hmm. And also she talked a lot with her. And I had a few of my patients were my close friends, which, she went and met them at their homes, and she spoke with a couple of my colleagues. So she got to have a little bit of a good image of what was going on. And she wrote all these stories. And so a lot of my dialogue, maybe most of my dialogue, comes from things I shared with her. So this is my participation, if you want. And then once she was done, she came back to New York, and we spent 3 days reading the script, making some corrections, but she really made the story. I mean, she took the information from me, but she created the whole story, yeah.
Gabriel, I think what you were getting at, Shanny, with your question is how much of your philosophy is reflected in this film. And I think we are really amazed when we had a call earlier to learn about that. And so could you talk a little bit about the breakfasts, the music, the sharing words? Is that just film, or is that the way you practiced during your career?
All of what you see in the movie where I am on the screen are things that are real, that I do. And she really reflected my philosophy so well. I mean, I was myself blown away when I read the script. I had tears in my eyes when I read it. So she really grabbed everything, and she's really a magician, because she was able to, many weeks of discussion, pages of writing, and actually the shooting was 3.5 hours. She concentrated all of that, and she came up with really all the messages that I was hoping to be able to share were in the movie.
I love it, and I love seeing this, and as a physician myself here at Columbia, I can think of all of the ways we fail to do what is reflected here, and probably everyone here has been a patient at some point. So I wonder if you have advice for those of us who are patients, as well as those from the medical school who are represented here. How can this sort of very human, really natural, really beautiful incorporation of life into sickness and dying, how can that take place? Can patients facilitate that? Can physicians and nurses and others in healthcare facilitate that? What do you recommend to people?
So thank you for this question. It's a tough one, but let me try to answer it the best way I can. Cancer is one of the toughest diseases we deal with, but we can extrapolate to any disease that any patient has. It's always the same tragedy, same drama when somebody has a bad illness. And patients come to you basically shattered. They feel that they're done, they have no more life, while they do. So I think we have to believe that as long as there is life, we can live as well as possible, despite everything. So I think this is the state of mind we have to be in as caregiver. And as much as we are fighting the illness, which I don't like, taking care of the illness, all right? We have also to take care of the patient's soul and emotions and remind that patient, hey, you haven't changed. You're the same person. You still can do everything that you do. You can love people, you can do things. You may have some limitation, but you can live as well as possible and focus on that. And I've seen a lot of time patients who, once they knew they had a death sentence, intensified the quality of their life. And this is where we can work. And I think there are no recipes or detail. It's a state of mind in which we have to be in. And this is the way we look at our patients. When we look at them as possibility of being great, they're going to feel great. When we look at them as victims and we look at them as they are handicapped people, they're going to feel handicapped. Same thing with the handicapped people. When you look at them like, less than who you are, they feel insulted. When you don't, they feel like you. So I think the way we look at people will make them feel differently. And you have to nurture that with every meeting. And very critical is to be 100% honest. I mean, patients come and they put their life in your hands. So if you don't tell them the truth, you betray them. They will feel it. They will know. Patients know what's going on, even if they don't say it. But when we say it, we can talk about it. If we don't say it, we're not allowing them to talk about it. And they keep it inside. And they start doubting what we say. And that doubt becomes worse and worse as things get worse. So transparency, honesty, integrity, they count on you. You can't betray them. So all of that build that relationship that changes this whole experience of being a patient.
My sense is that this isn't a very typical kind of setting for a cancer wing, and so I just wonder how you came to adopt this philosophy of absolute honesty, and I also want to ask you to talk a little bit more about that, if there are ever times when people don't want you to be fully honest with them, maybe, and how you respond in that situation. But how did you come to develop this kind of philosophy for working with people who are dying and the families who are supporting them?
I would say I grew up in a family where we've been always very straight, honest. My parents, myself, my sister, we never like lied to each other or hid things from each other. We've been used to speak really straight, say the things the way they are. So I grew up this way. So when I became a doctor, I naturally, I felt this is what I should do. Actually, I would say I have once hidden the truth from a patient when I was a fellow, and I was here at Columbia, by the way, and it taught me a lot. And after that time, I wanted to be nice, quote unquote, and I realized it doesn't work. And I said, never in my life I'll do it again. And that experience as a fellow one time was a really big lesson for me. So, you do it, and the more you do it, the more you feel comfortable about it, the more you feel comfortable about death, about illness, about bad things. When we're comfortable talking about something, well, people talk about it naturally. When we are scared to talk about it, when we are not comfortable, they're not comfortable. It's not like when you talk with the children about sex education. If you're not yourself comfortable talking about it, they're gonna feel bad. Mm-hmm. But if you're comfortable, they're gonna think it's normal and natural. So our state of mind is always what guides things.
Gabriel, I have to jump in. There's a study performed a few years ago that found that parents were more comfortable talking with their kids about sex than they were with their aging parents about death, which says something, right, about our culture.
Very interesting.
Yeah.
How much is in medical training, how much is a discussion of how to talk with patients about death and dying incorporated into the training of medical students?
Yeah, unfortunately, the way medical school curricula are crafted is that there are so many boxes to check. The students have so many things they're required to learn that it leaves very little time for the things that often end up getting pushed to the margins, like how to have these conversations. So I think in most medical schools, there's about 1 hour of formal teaching on how to deliver bad news, which would include things like talking to patients about a bad prognosis or even death. So it's very rare, and then, I teach ethics, so we end up doing a lot of supplementary work to try to have these conversations outside of the formal curriculum because the students aren't getting them, to make space for students to learn, to talk about this. And, you talk about our comfort with going there and facing fear. Some of that just starts with very basic conversations. Mom, have you ever thought about what it might be like to be in the hospital and be really sick? Just starting with a very basic question. Have you thought about a breathing machine? Have you thought about CPR? Have you thought about where you want to spend the rest of your life if, God forbid, you get that diagnosis? And having these conversations before people do, like in this film, get that diagnosis is important. Some people say you should start in your 20s. I have kids who are teens and preteens. I think it's never too early to start talking to people about mortality, because the fact is that we're all mortal. We all have to face death at some point, and I hope, my children don't face my death anytime soon, but they'll certainly see their grandparents' death sooner than later, and these are the facts of life. So just basic conversations help us warm up to the idea. I don't know how you approach that.
I couldn't agree more with you, but I think that we have to maybe give a lecture and explain to the students, but nothing replaces being next to you when you're doing it and when you're talking to a patient. And I think the students need training, and the fellows as well, next to a more experienced doctor who is comfortable doing it, and they will see. And I know that when I have students with me and they spend usually 3 to 4 weeks, they come out and they're really happy to have seen this happening, and I know they walk away with something that they really learned. So, but I think this is really where they will learn. It's really in the battlefield.
Yeah. No, I think that's right. I think that's right. And one of the programs that Columbia has here is to have the students the option of spending 2 weeks or 4 weeks with the chaplains. Similarly, who have time to spend at the bedside, dedicated to sort of engaging the kind of existential fears that patients are facing as they're processing this news. And so I know from many of our students have also found that time with the chaplains to be particularly rewarding and giving them the language, the way to approach patients.
We're lucky to have chaplains. We have a wonderful team of chaplains and they do a great job at the hospital. However, breaking the news, breaking the bad news, it's the doctor's role. And they need to see that. They need to hear how we break those news and how we handle those conversations, because nobody else can do it but us.
That's right, that's right.
I think we're going to have another question or two and then have time for questions from the audience. So if you have a question, there are microphones at the front of each aisle. So please feel free to come and stand by microphone and we'll get a sense of how many questions there are. I was struck, one of the questions that he talks about with his acting students is, what is presence? And one of the things that strikes me about you in this movie and about, I assume, how that reflects your practice is the presence that you bring to your interactions with patients. And I imagine that is hard to sustain when you're working with people who are, one after the next, who are going through this incredibly intense process. How is it possible to not experience burnout and to be able to have that kind of loving, warm, generous presence with patients?
Yeah, the burnout obviously is a big topic nowadays, and we have a lot of burnouts around us. We have, unfortunately, students and doctors who commit suicide, and all of us experience that in colleagues or students, and that's really horrible to see that happening. And part of it is burnout, obviously. My way, I don't think I've ever experienced burnout, by the way, although I've been practicing oncology for almost 40 years. My feeling, I may be right or wrong, my recipe for it is tango. Actually, tango, I find that tango really explains it. Tango is one dance where you have to feel the body of your partner and every vibration and every movement. If you don't move in harmony with your partner, you trip together, and both of you will fall. So I feel that we have to dance closely with our patient emotionally. We have to feel our patient's emotion and work with that. We have also to have a realistic expectation for what we are doing when we treat patients. We have to have it for us and for them. And if we set our expectation realistically, and we achieve the goal that we set, then we feel good about it. So those conversations, those consultations one after the other, have a very precise goal with every conversation. And I try, I don't always succeed, I wish I could every single time, but I completely try to isolate my mind from anything around me, to be with the patient. This is what presence is about for me, to be right there for them, close to them, spend that whole moment with them. And that's what will get that consultation really helpful. And will make me feel that I've done what I have to do. So I can move to the next patient without feeling exhausted from the first one. Now, of course, sometimes you have exhausting situation or people, you put up with it. But by and large, I tell you, I love my patients. I enjoy seeing them, most of my patients I love seeing.
Can I ask you a question? What struck me, so this is my second time seeing the film, what struck me was the attention to relationship. Not only reconciliation where that was needed, but also sort of resolution. I mean, you even get a resolution with Eugenie in the end. And this is one way that this movie is characterized is as a mother and a son's relationship. It's far more than the mother and the son. it's far more complicated than that. And I was wondering if you could talk about, in your experience, the power of reconciliation and also where that is, it just falls flat. And what to do, I mean, what any of us should do in those circumstances.
So I bet every one of us has unresolved situation or problem with relations. Could be mild, could be very serious, could be tragic, could be drama in families. So you have all the different, things happening. And I think that having peace about all these issues empowers you. And whenever we are in a crisis, these things that we thought were like under the rug, come out and haunt us. And the sicker we are, the closest we are to a death sentence, the more they haunt us. And I think it tortures the patients. They don't have the chance to say to you, though. They don't have to even sometimes know that that's what they are experiencing. So that's why I think it's really critical to try to open the eyes of our patients that this is the time to get your affairs together. Actually, I do one trick with my patients which makes them laugh. When they have a bad situation like in the movie, I actually take a white piece of paper and I draw 2 columns. I say this is like the simplest Excel sheet in town. And we're gonna put down column A and column B. And I tell them for the next time when you come to see me, you're gonna take it with you. You're gonna put on the A column all what you love and what you're passionate about, all the people that you enjoy seeing and that you love seeing, and everything else. You don't have to hate it, but if you don't love it, column B. So let's fill up your next 2 weeks with A stuff. So they suddenly feel empowered. And then we joke about it, like you tell the husband, listen, you better behave so you stay on the column A. So they start laughing. You have to joke about these things. And then so, they come next time and say, what movie did you see? You can create things like that, and you give them the feeling that, hey, you're alive. It's not because you have a cancer that you have no life. So this, again, you nurture it. You help them do that. And then, of course, you will sometimes start realizing there's something wrong. I don't get involved in the family stuff, but I try always to push them. And many times I've seen some miracles happening by the end of life where there was reconciliations. And this is an incredible thing when you see it happening.
Do you ever use the language of hope with your patients? And then how do you distinguish hope from sort of false hope for a cure that's impossible?
Yeah, it's really important to be precise in our definitions. And the word hope comes all the time. And whenever treatment don't work anymore, say, so you give up hope, and I have no hope. Then I say, let's define hope. What's the hope now for you? The hope is that you get the best quality of life, that you feel well, you get the best of what you can get for whatever time you have. This is a hope that we can hope for. But hoping to cure your cancer, you're gonna fail. You're setting yourself up for failure. So I really try to make them shift to having a different goal for their hope. And people take that.
I think we have some questions, so give members of the audience an opportunity to ask a question now. I'm sure everyone here has experience with someone in their family or someone close to them who's had cancer or another serious illness, and we want to really keep this to questions rather than talking about our own situations, because we really want to take advantage of our speakers. So I just encourage you to ask questions and keep them relatively short. Thanks.
Yeah, I want to say that I really just love the movie. Can you hear me?
Can you get
Closer to the microphone.
Can you hear me? Good? Okay. I really love the movie. I was just curious about the crossing the boundary of the professional and the patient. And why was it put into the movie? Does it really happen in the in real life? And what kind of, because we're all human, what kind of professional discussions do you have with the staff?
Yeah, first of all, remember this is a movie
Yes.
and a fiction,
Yes.
okay? And I can assure you that any of us here who's a physician, if he has a nurse who behaves the way Eugenie behaved with her patient, she'll be fired the next day. Period. No matter how much I would love my nurse practitioner, if I knew about it, I just can't work with her anymore. So I think this is clear for all of us doctors here, and this is something very black and white for us. I heard that it happens sometimes. I've never seen it happening in my career, but I think this is the fiction part that Emmannuelle Bercot put to the movie. I personally would have removed that scene if it was up to me to cut the movie, but I'm not the movie director.
Right.
I didn't write the script, so I don't own it.
Okay.
But that's what it is, unfortunately. That's the story. That's my best answer for you. So that's boundary we cannot cross.
Yeah.
Clearly.
I assume I was wondering why I was in the movie, but, okay. You
So going back to Hippocrates, it's actually in the Hippocratic Oath
Yes.
that you don't have sexual relations with your patients of any sort.
I know
So,
that.
yeah, it was a little horrifying for me as an emphasis,
Okay.
but yeah.
Yeah, okay, good. All right.
You would be surprised that in France, they were not surprised.
We have different boundaries.
You know, it's a French movie at the end of the day.
But just to extend on that for just a moment, it does seem like you encourage, in the breakfast conversations, for example, you encourage nurses and doctors to really be with their patients, and that it's okay for them to express emotions and to cry so it does seem like there's less of a strict sort of barrier of professionalism in the practice, at least as it's portrayed in this movie.
Yeah, so I will tell you one thing is that I don't think in the textbooks or in the teaching, in the culture, it seems like it's an accepted culture that we have not to show emotion. We have to have a shield for our emotions. I don't think it's taught in medical school. I think it's just like people think this is what it is. And I don't agree with that at all. I think there is one thing that I really feel we should be present to and not accept. The doctor is here, and the patient is destroyed down here. And that relationship is absolutely unfair. We have to level down and make the patient understand, I'm human like you.
I do think it's changing though. I think some of the younger generations are more willing to show emotion. I just finished a month in the hospital up here with a lot of trainees, and I was really amazed by the level of emotion that some of them were willing to show and the humanity that they shared with their patients. And so hopefully, burnout won't beat that out of people, but that the younger generation of doctors will continue to go on and share that emotion.
Yeah, I think it is changing, you're right, and it's changing in the right direction. But we have to make our students not think because they had maybe one tear coming down or because they were looking sad that they made something wrong. Because they feel guilty that they were not tough, No, be yourself. No, of course, as I said, you don't have to be like crying and then need somebody to hold your hand. No, our job is to hold the hand of people. But showing that we are sad about something is completely human, and patients feel that you really are on their side when they realize that you also are not feeling happy about what's happening. So, of course, there is a fine line.
Next question.
I'm sorry.
Oh, wow.
Be quick.
Okay.
I'll be quick.
Well, since I pointed, you'll be next. All right.
Just, I had a question.
You do need to get really close to the
Okay,
mic.
I had a question about the influence of time with patients that might have occurred. I'm very used to doctors being very aware of the time and that they're working on the clock. And I wonder if you could speak to that, because there was a real beauty in the sense that didn't happen in the film, but to me, I wondered how realistic it is.
So I'm a primary care doctor, and I felt the same way when I watched the movie. I have 15 or 20 minutes per patient, sometimes less, and yes, there's no choice but to watch the clock. Dr. Sara is a different kind of physician, right? You were running an infusion center for cancer patients, which is a different kind of time that a doctor is able to spend with a patient. So I think some of it is probably the difference in discipline, but what would you say?
I actually refuse to have my patients scheduled every 15 minutes. Period. At times, actually, I don't let them do that. So I get sometimes criticized by administration, and that's okay. But I think it is not something I could do, having patients with such heavy diagnosis and make them feel that while I'm talking to them, I do that. And how can you be present with them when you're thinking about the time? And unfortunately, today, a word that I really don't like at all, medical industry, we're being pushed to see more patients in less time. Nurses are overworked and have to see much more patients with much less staff. It's horrible. I think this is something that needs to be tackled, needs to be changed, because it's only getting worse. And then, I'm sure you've seen it over the years, it's getting worse and worse, and that's gonna burn out a lot of people, it's gonna discourage people from being doctors, and it's gonna increase the lawsuits. They're gonna pay the price of what they think they save by making you see more patients with lawsuits. And people will die, people will be sick, because we have to go fast and see more patients in less time. It's horrible.
Okay, over here, and maybe we'll ask 2 questions, and then we'll make sure that we get through everyone's.
We just have a quick question. One, we were wondering whether you actually did the tie thing, and if there were other small things like that you did to make your patients feel brighter.
What was the second question?
Do you
Yes,
really do the tie thing?
Yeah, and the other one?
And the other
And
one was,
are there other kinds of things that you do to make patients feel comfortable or to make a connection with individuals?
Yeah, the side is true. I do have maybe.
Yeah, no tie
Not
today.
today I'm informal, but at work I have maybe 30 different ties with little animals, different animals, which I adopt with the patients. Actually, the first time I had one was a patient of mine who told me a story about the love bugs that she would see in her kitchen when she was feeling well. So love bugs for her became a sign of hope. So I was telling the story to my wife, and she came up with the idea, well, why don't we offer her something with love bugs? So she actually got, I think, first time earrings with that, and then she got me a tie with love bugs on it. And my patients was so happy when she saw me wearing that. And I realized that actually it's something that really brings joy, which is nothing, it's a little thing. But also, again, this is my wife told me that one day, said, when you are seeing a patient, they are very close to you physically. You're examining their lungs, palpating their belly. It's uncomfortable. They don't know what to look. They usually look at your badge, to see your name. But when there is a tie, they have fun looking at it. So I tell you, it became something I've done a lot. And so Emmannuelle knew that. So that's why. There are no recipes you invent. You just have to be present to who your patients are. And you create discussions that are tailored to each one. So
Gabriel, it seems like all of your good ideas come from your wife. Is that fair?
definitely.
thank you.
Okay, next one.
Good evening. So I have 2 questions. Can you hear me?
Yeah. There you go.
Okay, thank you. So first question is, how many proportion of patients are worried about side effects like losing their hair? Because it seems that was a big concern for the main actor. The second question is, how do you reconcile helping the patient have acceptance of the inevitable, potentially, with potentially having them participate in, say, an investigational therapy, like, say, in a clinical trial?
The first question, I would say almost everybody is worried about losing their hair. There's no patients. Even people who have bald like me will worry about losing their hair. Okay, and you don't have to coach them to lose it. But can you clarify your second question for me?
So the second question, how do I explain it? So essentially, in the movie at least, it was clear that the doctor wanted to help the patient have acceptance. And acceptance, in fact, in the first sense, right? But then, we know that it's possible that there could be a new therapy that maybe is not yet approved, but it's in clinical trials, right? So are there instances where maybe the doctor is aware of that and then recommends that? And how do you make that decision that maybe you should recommend to a patient that they participate in a trial? Does it make sense?
Yeah. So first of all, we're trained to be aware of the various trials available, and we are trained to also search those trials. None of us knows every trial in the world, but we know how to search them. We have team who work on telling us what are the available experimental drugs, and it's our job to evaluate who is the patient who is a good candidate for a trial or not. Sometimes there is a good drug, but the patient is not a good candidate. So this is a clinical judgment. But once we feel this way, then we have to sit down and explain to the patient, the options, and make the patient understand what it means to be on it or not on it, and respect their choices. But you need to make them on your part of your team. I never look at the patient as I run the show and I tell you what to do. No. You sit by next to me, and then together we're going to look at your options and think about what is best for you, if you believe in it. So that's how we can get patients to go on trial or not.
Makes a lot of sense. Thank you.
I think I know the answer to the question, but I want you to confirm it. Early in the movie, you say that the patient decides when to die. Fiction or fact?
Absolutely facts. And I can just write a book about how many times I've seen it happening. I really strongly believe that there is some control over the last few hours, sometimes maybe a couple of days, where patients will decide when and with whom they will die. I can spend the evening telling you stories about it, but it's a real thing. And as a matter of fact, when I have a patient who is at the end of his life, I bring the family to a meeting room and I tell them about it. And the reason why I do is that everybody wants to be holding the hand of their loved one when they're dying. And it happened that, like in the movie, you leave the room and the patient dies. And you feel guilty the rest of your life. I shouldn't have gone for this coffee. I should have waited a little bit more. I should have not gone home, etc. And it haunts you. And I tell patients, the power is in the patient's hand. You have to empower them and tell them that whatever they want, you're gonna be okay with. And when family hears that from you beforehand, when it happens, they will tell me, you were right, it's happened like you said. But if they don't know that, even if you tell them this after the fact, they will still think, I should have not left the room. So it's real, it's true, and we have to coach the families about it beforehand.
Thank you. I'm afraid this was not my answer.
Great movie, and this is a very good segue for the question I have, because it has to do with the families letting go and permitting or allowing their. So I have lived two situations. One with my own father, and I made it. I live here. He's in Cairo. I made it while he was in coma, and I find myself having to go into his room and really asking him to let go. And I lived with great pain and regret until a friend of mine here who was dying of cancer, and his family were all doctors, and they hung on to him to the point where the dignity of life has disappeared practically. It was painful. And I'm still having a hard time really reconciling the permission I gave my father to go. So it's very difficult. So the question is, in your talks with the patients, when do you say enough? When do you say it's time to...
Enough to the family or
to the family, yes.
once process of dying starts, I sit down, the conversation I have is about what happened, whether they will be here or not, to just prepare themselves, and the permission to die. I say it always. And you're giving them a tool to give a gift to the loved one, which is, I'm gonna be okay, you can go. And it's a very important conversation with the family. And the reason why I do it is, first of all, for the family peace, but even more importantly, for the patients. Because the patient will have that peace he or she needs to have from their family and their doctors allowing them to die.
Okay, so I'm not using you as a clairvoyant or anything like this, but in the case of trauma, do you think my father heard me when I said, it's okay to go, don't be afraid? He did. Okay.
Patients always hear you. Patients always hear you.
Okay.
Yeah. Anyway, we have data coming out of Columbia that shows that even patients who are completely unconscious by all measurable standards with traumatic brain injury on functional MRI still are able to, some of them, not all of them, but still are able to show high-level executive brain function. So always assume that people can hear you, that they know that you're there. Talk to them, love them, hold their hands. They'll know.
All right. Thank you so much.
Hi, thanks for the movie. I should have brought more tissues. So my question is, how do you handle situations where the patients or the family are in denial when they find out about the news and throughout the process of chemo, especially when this is culturally driven, since different cultures have different attitudes towards death and acceptance?
I didn't hear the last few words.
Oh, how do you
I
handle
understood the
denial?
question, but at the end, what did you
Especially
say?
when it has to do with the way different cultures handle death or accept it.
Oh yeah. I mean, being in New York, this is the best place to train about talking to every culture, every religion, every color, every country, and I can tell you, there are two things all of us have in common. We are born the same way, we're gonna all die, no matter what your culture is about. And I'm Lebanese, as many of you know. I do go to Lebanon on a yearly basis or more. I end up seeing patients, sometimes family come to see me in Beirut or come from Syria. I see in New York people from everywhere, China, Pakistan, India, South America, Canada, you name it, Europe. And you have always somebody who tells you, in America you always say the truth, but not in our country, people are not used to the truth. I hear this all the time. And long time ago I decided I'm not gonna accept that conversation, and I don't. And I always put my rule, if they want me to see somebody, that listen, I'm gonna be very honest, and I will tell them the truth. But if you don't want me to, I don't see the patient. And I have refused to see patients when family did not allow them to come to the consultation to hear the truth. But when I say the truth, I'm gonna get some people angry. This is no question about it. I can tell you uniformly, all these people who were angry come back and apologize and thank me because it helped them. But culture-wise, it works with all the patients. However, as caregiver, we have to listen to the kind of culture we are dealing with, and the style of the things we will say will change, but not the content. The content has to be always 100% honesty, but you can speak in a different way with different people with the same message. So I've had no trouble with any culture, I can tell you that. Never. People think it's crazy that I say that, but I can tell you it's true.
Thank you.
Hi. Would you speak a little bit about your own musicianship and joy in music, and whether you've had the opportunity to share that with your patients as well as your staff along the way?
So another thing I was very blessed with was music. I grew up in a family of people who love music, sing, play. We had choir in the family in the past. So music has been very important in my life. And when I discovered music therapy, which I didn't know existed when I came here, of course, it was like an incredible gift for me to have to work with. And so we have a very strong music therapy program at Mount Sinai, one of the top actually in the world. As I tell you, the director is one of the most known music therapists in the world. I've been to international convention where I realized how big she was, and she is. So I realized that music is really important, but music therapy is not music. Music therapy is trained therapists who use music as a tool for therapy. And it's a total different experience. And music therapy is a topic for 2 hours of discussion, but music therapy is very important. I think that I would hope to see it in every single hospital and in every department. It helps patients, and it helps families, it helps caregivers. I've seen nausea markedly improved with music therapy. I've seen pain markedly improved. And think about the side effect of morphine versus music. And what is more expensive? What is better for the patient? So music therapy is really important. It is a growing field. It's becoming really recognized, but I hope it's gonna be really everywhere. I do play music with my staff, and I play music with my patients sometimes.
Hello. Hi. Congratulations on the movie. I just love it. My question is, when you told a patient that he had between 6 and 12 months, how often really in real life you think like patients beat the statistics for better, like to really not being a number, even though that they have like between 6 and 12, how far they can go beyond the statistics?
Okay, I will answer something. First of all, I don't say to every patient upfront, you have 3 to 6 months. I'm not God, I don't know that number, but I know statistics. And I will give them those numbers. The only thing I hold upfront is the time that they have till they want to hear it. That's why you can see here, I say, if you want to hear it, I will tell you. So I always want them to want it, to hear that. I would say most of them ask you at some point, okay? But we have been all wrong about it. I've had patients that we made DNR, which means donor resuscitate, who lived 6 years. So you have to tell the patient that statistically that's where you fall, but you're not a statistic, you're an individual, and things can be different. So I've seen that, no question. All of us doctors have seen patients who recovered in an incredible way and are still around.
Thank you. And can I just do a follow-up question because of the music therapy? How do you think like integrative medicine has really helped patients? Because I know that there's a lot of
Can you
things
speak
that
closer to the microphone?
there are a lot of treatments that like it's not real medicine in terms of like it's proven, but how integrative medicine do you see that has helped patients as well to prolong their life?
It does not prolong their life. No. It makes their quality of life better. It makes their coping mechanism better. It gives them a lot of emotional comfort. But it doesn't have an impact on the result of the treatment. I don't believe so.
Okay, thank you.
Hi, wonderful movie. My question is not serious or has nothing to do with medicine, but I was just curious. How was it like to work with Catherine Deneuve so closely?
Thank you for this question. Yeah. Yeah. So Catherine Deneuve is this icon, and people think that an icon in real life is sitting next to you as an icon. It's not true. She's another person like you and me. Okay. And if you look at her as an icon, she behaves like an icon. But if you look at her as a friend, she'll be your best friend. So I happened to meet her the first time. They took us actually, when we arrived in Paris, Laurent and I, for the movie the first time, the producer and the director took me for dinner with her. We were only 5 people, to just kind of get to see the chemistry between her and me. And it was amazing. She is just the most wonderful person ever, kind, nice, timid, and we had a wonderful evening together. We became friends like right away. So being on the shooting the film with her, as well as Benoît himself and Cécile de France, They were all such wonderful people. I was so spoiled to be with such great people, each one as a person. So we built a very good relationship together. We love each other. And I think it's part of why this movie was a success, because we were really close to each other. I can tell you, I made a lot of mistakes many times. I ruined some scenes because I made a mistake while everybody did a great job, and I was, the only guy who was not a professional. They were always supportive of me, and they were always helping me. So it was an incredible experience. Wonderful person.
Well, maybe one last question for both of you before we wrap up, which is, do you have advice for people who are supporting someone who is dealing with a terminal illness? What is the best way that people can support friends or family who are going through something like that?
What immediately came to mind is make sure you have a backup, because this is some of the hardest work that people do. They often put careers on hold. It's unpaid, it's unrecognized, and it's so meaningful, but you can't do it around the clock, day in and day out. You need help. And so finding a team, creating a team, and if a team isn't possible, having at least one person who can back you up and give you a day off, give you hours off at regular intervals is so important to be able to sustain that work long term.
Yeah, and I would add to what you said is it's important not to look at our families, our patients as victims. I don't think anyone likes to feel that they are a victim. No one. And I think you always need to strongly convince yourself that you are in front of a possibility. These patients are a possibility to be extraordinary people, and they will be. When you look at them as handicapped, they're going to be handicapped. So you always have to talk to that part of creativity, of dreams, of beauty. When you look at them this way, you see the difference. And your language will be different. I never prepare my sentences or anything. I prepare my state of mind. And your state of mind will change what you say to people, the way you look at them. And you have to also, I sit down with the families, and I also try to really make them understand that they should not treat their loved one as handicapped. For example, I have many stories. One of them would be this close friend of mine whose wife was my patient, and her sister-in-law called me up. She told me, listen, they're coming for Christmas to our home, and every time she comes, we fight with her. What can we do? Because this was her last Christmas together. They knew she was dying. Said, what can we do? And I immediately saw the situation. That patient of mine was a very accomplished professional, always running her life very professionally, wonderful woman. And I told her, well, I think what happened when she comes to your home, you hold her hand, you constantly take care of her, you don't let her do the dishes, you don't let her do that, while she is a very energetic woman. And I think she hates it, because you make her feel sicker than what she already is. I said, listen, next time, let her do the dishes, make her cook something for Christmas, don't carry her luggage unless she asks you to carry her luggage, treat her like everybody else, argue with her, and you'll see how it will be. So when I said that, she suddenly saw that, she shared with us, and they had a great Christmas. She cooked, she did things for them, she had energy, but they stopped take care of her as a handicapped person.
Thank you so much, Gabriel Sara and Lydia Dugdale.